Garbosa criteria for diagnosis of STEMI in the setting of left bundle branch block. 5 points for ST elevation more than 1 mm in any lead with positive QRS, that is V4, V5, V6, AVL or lead 1. 3 points for ST segment depression more than or equal to 1 mm in V1, V2 and or V3. T segment elevation more than ST segment elevation more than or equal to 5 mm in any lead with discordant QRS V1, V2 and V3 carries 2 points. As shown in figures, normal left bundle branch block V4, V6, AVL and 1 and ischemic left bundle branch block with ST elevation. V1, V3 normal left bundle branch block on the left side of, and then there is ischemic left bundle branch block with 3 points for ST depression. V1 to V3 normally, and these complexes shows the normal expected appearance and the ST elevation in setting of left bundle branch block and ischemia. So Garbosa criteria A is concordant more than 1 mm ST elevation. Criteria B is ST depression concordant V1, V2, V3, and criteria C in any lead 5 mm or greater ST elevation in a left bundle branch block or paced rhythm as per Garbosa criteria. So when you suspect MI with LBBB and patient is hemodynamically unstable or acute heart failure, you go for PCI or fibrinolysis. If no, then you look for Garbosa score more than or equal to 3. If yes, then go for PCI or thrombolysis. And if no, then you look for ST to S ratio less than or equal to -0.25. If yes, PCI or fibrinolysis, and if no, then you perform serial ECGs, serial troponins and bedside echocardiogram. If they are abnormal, go for angiography. If they are normal, then you go for non-invasive evaluation. Garbosa criteria 3 or more than 3 points are highly predictive of ST elevation MI. Again, the same thing, but in a new figure, discordance of 3.5 mm, not an acute MI. In new Garbosa criteria, the third rule is STE to S ratio more than or equal to 0.25. So if ST elevation is 3.5 and S wave is 10.5 mm, then ST by S 3.5 by 10.5 is 0.3, and this is an acute myocardial infarction.